Dr. Duvoor is going to talk to us today about osteoporosis management. So kind of switching gears from the diabetes focus here. So Dr. Duvoor works in Jonesboro. He is a endocrinologist there, and he's board certified in endocrinology. He graduated from Bangalore Medical University in 2002. He completed his residency and fellowship in York, United Kingdom, and UAMS in Little Rock, respectively. Dr. Duvoor?
Good morning, really. We're going to talk about osteoporosis. More than 10 million Americans have osteoporosis, and that is the 43 million have low bone mass. More than 2 million osteoporosis-related fractures occur each year in the United States, and more than 70% of these occur in women. For women 55 and over, cost of caring for osteoporotic fractures exceeds the cost of MI, stroke, and breast cancer. And unfortunately, mortality after a hip fracture is about 12 to 20% over 2 years. By age 60, half of all white women have osteopenia or osteoporosis, and by age 75, half of all women have osteoporosis with an average T-score of minus 2.5. Even still, more than half in one study, 80% of fragility fractures are in women with a BMD, that is osteopenic range. So we will talk about the women case. Ms. Jones, a 60-year-old female, is eating her 2-year-old grandson. She bent down to pick him up, and there was a back pain. She pulled the muscle. She took some pain medication to her counter. Pain progressively getting worse, that she's unable to sit and presented to the clinic 3 days later. We got an X-ray that shows variable function fracture. So she had oophorectomy at the age of 35 due to endometriosis. She was currently on HRT. After surgery, however, developed a DVT that was thought to be due to her HRT, and this was discontinued. And she takes vitamin D rarely and calcium occasionally. She walks about a mile 2 to 3 times a week. She had a bone density at her last appointment 2 months ago that showed this. It shows normal T-scores, and so is her spine. So the question is, does she have osteoporosis? So osteoporosis is defined by T-scores minus 2.5 or below in the lumbar spine, femoral neck, or the foreproximal femur or distal motor radius, or a low trauma spine or hip fractures regardless of the bone density. A T-score would be minus 1 and minus 2.5 and a fragility fracture, either the proximal humerus, pelvis, or distal forearm. A T-score between minus 1 and minus 2.5 is a high frac score. And a fragility fracture is one defined by, that is caused by a degree of trauma that is not expected to cause a fracture, for example, fall from standing, or height or low. This excludes toes, fingers, face, skull fracture, and ankle and rib fractures. So who should get bone density? Both the ACE and USPSTF recommend that BMD testing for all women aged 65 and older, as well as in younger postmenopausal women, increased risk of fracture for bone loss and fracture based on FRAX analysis, but also women who are on steroids with low body weight, or their long-term steroids for family history of osteoporotic fracture, early menopause, smoking, and alcohol consumption, or diseases that cause secondary osteoporosis. So screening intervals, so test 10 is recommended every 10 years if you have a T-score of greater than minus 1.5, a T-score between minus 2 and less than 0.5 every 3 to 5 years, and they are good health. A T-score minus 2.5 and less than 2 every 2 years, or a T-score less than minus 2.5 every 1 to 2 years if they are on 3. And it's best done at the same machine by the same technologists, so that you get a good quality report. So these are the various diseases and medications that cause secondary osteoporosis. And medications that cause bone loss are steroids, aromatase inhibitors, androgen deprivation therapy, anticonvulsing agents, cytotoxic agents, immunosuppressives, intramuscular medroxyprogesterone, EDIs, and hydroxyl hypothyroidism. So medications associated with increased risk of fractures are FIPAs, SGLT2 inhibitors, insulin that causes hyperglycemia, SSRIs, SNRIs, opioids, and benzos. So when we evaluate somebody with osteoporosis, we get a CBC, hydroxy-D, the TSH, EKH, phosphorus, magnesium, CUP, a liver function test, especially you mentioned alkaline phosphatase as well. And in men, it's important to get an 8 AM testosterone. So also we can get a 24-hour urine calcium-creatinine ratio after replacing vitamin D and patient consuming adequate amount of calcium for 2 weeks. If their vitamin D is not depleted well enough when we are trying to diagnose patients with FHH or malabsorption syndromes, this can be misleading. It's always important to replace the vitamin D and calcium before getting this test. You also, if you suspect somebody has celiac disease, to get a facial transglutaminase. If you suspect somebody has myeloma, to get the next fresh and also UFEP. Also, if you suspect somebody has Cushing's, to get a phenfolate cortisol, or bone marrow infiltrative diseases, very rarely you don't get a bone mat. So how should Ms. Jones be treated for osteoporosis? So these are the various agents. We have bisphosphonates, estrogen, reboxetine, denosumab. Anabolic agents that include teriparatide and abaloparatide. And the other agent that is both an antiresorptive and an anabolic agent, this is romosozumab. And avoid using strontium. It's not FDA approved. There is small increase in DDTs. And avoid using calcium, fluoride, and kibolo. So how do we this satisfied and how do we decide on what treatment should Ms. Jones be on? If this patient considers high risk, that is fractures within the past 12 months, multiple fractures, fracture or bone loss while on treatment, fracture while on medication, anchored to the bone, or very low T-score that is less than -3, or very high FRAX score. Romosozumab is recommended, or EDH analogs, teriparatide or abaloparatide, alternatively denosumab or bisphosphonic zoranolic acid IV can be considered. High-risk patient is a patient who has had prior fracture, a T-score of minus less than 2.5, or a T-score between -1 and -2.5 and a high FRAX score probability greater than 20% for major osteoporotic fracture or greater than 3% in the preferred agents are denosumab, bisphosphonic, alendronate, zoledronate, or isotonic. Alternatively, alendronate or raloxifene can be considered. So you look at bisphosphonates, inhibits osteoclast-mediated bone resorption, decreases mineral release and collagen or matrix breakdown in the bone. So we have alendronate that we take it orally, risodronate, alendronate, and zoledronic acid that is IV. In clinical practice, they use mainly alendronate and zoledronate for obvious reasons. So it decreases vertebral fractures by about 44% with alendronate, and kip fracture by 40%, and non-vertebral fracture by 70%. With zoledronate, it's 56% reduction and 42% at the hip, and 80% non-vertebral fractures. So common adverse effects of bisphosphonates. Oral bisphosphonates need to be taken on an empty stomach 30 to 60 minutes prior to food. They have to sit, they should not be sitting, they should stand, avoid esophagitis, and consider ID with patients with comorbid gastroesophageal reflux disease. For IV zoledronic acid, there's an acute phase reaction, flu-like symptoms, usually myalgia and cachexia is common, one in about 4 patients, but usually after the first infusion lasts about 1 to 3 days in clinical practice, sometimes to 7. But I usually tell my patients to take an NSAID or Tylenol pre-op and preemptively. And the frequency and severity can be reduced by, like I said, mentioned, acetaminophen. So the adverse effects, again, due to concerns about renal toxicity, bisphosphonates are indicated only for patients with eGFR 30 or greater for accelerated alendronate. and 35 ml per minute for hyaluronic and zoledronic acid. But hypocalcemia is usually transient and more likely with IV use. And ONJ and AFF will speak about this at a later time. But before considering highly bisphosphonates in patients who have EGFR or gross ectopic effect, it's always important to have a conversation with the nephrologist that is for your patient. Talk about denosumab. Is a monoclonal antibody that targets crank ligand. It binds to crank L and inhibits its binding to crank receptor, thereby preventing osteoclast formation. This results in decreased bone resorption and increased bone mass. So does it work? So this freedom trial, there were about 8,000 women between 60 and 90 years of age, BMD less than -2.5 but not less than 4 at lumbar spine or total hip, randomly assigned to receive subcutaneous injections of denosumab or placebo every 6 months for 36 months. Primary endpoints where they will look at vertebral fractures, secondary endpoints were non-vertebral and hip fractures. There was a 68% reduction in new vertebral fractures, there's 40% at the hip, and there's 20% reduction at non-vertebral fractures. So the adverse effects, hypocalcemia is concomitant. The concomitant medical conditions such as malabsorption or CKD and osteoblastic metastasis. Again, these are quite rare, osteoblastic mets, but it's always important to know what type of bone nets do they have before consideration. We had several patients who, as in Perishuk, unfortunately received denosumab, had to be in the hospital with severe hypocalcemia for close to 6 months receiving IV calcium therapies. In contrast to bisphosphonates, denosumab may be administered to patients with CKD. It is effective at reducing fracture rates and increasing the BMD all size in patients with CKD 1, 2, and 3. But stage 4 CKD compared with placebo, denosumab decreased BMD at hip, but no significant effects on fracture rates. Again, also in considering denosumab in patients with CKD stage 4, it's always important to look at their vitamin D status and their calcium levels before considering this agent. It's generally well tolerated. There is no increased risk of malignancy or skeletal fragility. Very small risk of cellulitis or skin infections. Eczema was 3 versus 1.7%. Again, some patients had back pain, lower extremity, and musculoskeletal pain. Hypercholesterolemia and cystitis bowels are noted. Freedom trials were extended to 10 years. It persistently improved a reduction in fracture risk and no worsening safety risk. So, rebound fracture is something that we see in several cases of patients who have been reported to have vertebral fractures within 3 to 18 months after discontinuing denosumab therapy, because there is rapid increase in bone turnover as the medication wears off. So dose of denosumab should not be delayed and should be administered on an every 6-month basis. If denosumab is discontinued, it's recommended to be administered an alternative agent to prevent rapid bone loss. There is never an indication for denosumab. So Mrs. Jones is now 65. Unfortunately, she's on an Advantage Medicare plan which does not cover denosumab. She was on denosumab for 5 years, so what should we do for her next? So now we talk about romosozumab. It is a monoclonal antibody that binds and inhibits skirostid. It's got a dual effect. It increases bone formation and decreases bone resorption. So does this work? So again, there was another trial, that is FRAGE trial. There was close to 8,000 post-menopausal women who had a T-score of -2.5 and -3.5 at the total hip or femoral length. Patients were randomly assigned to receive romosozumab or placebo for 12 months. Thereafter, patients in each group received denosumab 12 months every 6 months. The co-primary endpoints were cumulative incidence of new vertebral fractures at 12 months and 24 months. At 12 months, new vertebral fracture occurred in 16 of 3,320 patients in the romosozumab group as compared to 59 in the placebo group. So it's representing a 73% lower risk in the bone view. At the 24 months, the rates of vertebral fractures were significantly lower in the Rome group and in the placebo group than who transitioned to denosumab. So this is given once a month for 12 months. Its use is limited to 1 year due to waning of bone formation effect after 12 months. Once discontinued, BMD unfortunately returns back to pre-treatment level. So it's always recommended to be given another anti-resorptive therapy to preserve the effect it was received. So this is Joan's treatment. Unfortunately, she had chest pain before and she had a left heart cath and she received a stent. So she a candidate for Romo? Unfortunately not. She's best avoided in women who had a stroke or CV event in the previous year. This was seen only in one trial, but again, it was not seen in other trials though. There were no cases of atypical femoral fractures or ONJ booters, but in one trial there was one case. Korean incidence of hypercalcemia was very low. So then we come to abaloparatide or teriparatide. Abaloparatide is a peptide analog of human PTH related protein, analog that acts as an agonist on the PTH receptor. It's administered 80 micrograms daily subcutaneous injection. Treatment duration is recommended for 18 to 24 months. But now the label is changed, you can use it again. Again, the teriparatide also synthetic fragment of human parathyroid hormone. It's administered as subcutaneous injection every day. The treatment duration is again 24 months. It was restrictive, but the US label now stated for more than 2 years during a patient's lifetime, but can be considered at a later date if the patient has returned to having high-risk fracture. Then we looked at active trial, a randomized multi-center double-blind placebo active control trial clinical study of postmenopausal women with osteoporosis. Around 2,500 women aged 49 to 86 years. Mean age was about 69, who were randomized to receive Timlos, 80 milligrams, or teriparatide subcutaneously for 18 months to assess the efficacy and safety of abaloparatide. Primary endpoints were incidence of new vertebral fractures at 18 months. Secondary endpoints were incidence of non-vertebral fractures at 18 months and DMD change from baseline at the lumbar spine, total hip, and femoral neck at 18 months. The study was not designed to provide head-to-head comparative efficacy data, but Antinop integrated as evidence of superiority or non-inferiority to teriparatide. There was an 86% of relative risk reduction in new vertebral fractures and 43% relative risk reduction in non-vertebral fractures. And you can see the BND improving within 6 months of receiving this therapy. So both these drugs needed to be avoided in patients who are at increased risk of osteosarcoma, or have had arthritis disease to bone, or if they've had bone metastasis prior skeletal radiation. Again, patients with hypercalcemia, unresolved hyperparathyroidism, and unexplained elevation of alkaline phosphatase, again skeletal malignancy or skeletal radiation. Teriparatide usually causes dizziness and leg cramps, with abaloparatide, nausea, postural hypertension, palpitation, headache, and dizziness can be seen. And this is pretty common, so we tell patients to take this at night when they're going to bed, especially if they're sitting. And they should be used in caution in patients who are active or recent had active TB stones. Once again this discontinued, bone loss can be rapid, so it's always better to follow up with an anti-resorptive therapy to preserve the effect. Now we talk about osteonecrosis of the jaw. Same as a complication with anti-resorptive agents, all of them, both denosumab, bisphosphonate, and also romosozumab. It's a non-healing wound in the oral mucosa with exposed bone that lasts for greater than 8 weeks. The incidence is much lower with oral or IV bisphosphonate therapy for osteoporosis in the order of 1 to 10,000 to 1 to 100,000 patients per year. These factors are patients with dental pathology conditions, or they've had invasive dental procedures, poor dental hygiene, or had cancer, chemotherapy, radiation, and anti-angiogenic therapies. Tooth extraction in a patient who's exposed to bisphosphonate therapy carries a 0.5% risk. If a tooth extraction or implant is planned or ongoing, initiation of potent antidisruptive agents could be deferred until the areas heal. American Association of Oral and Maxillofacial Surgeons recommend a 2-month drug holiday for those who have taken bisphosphonate greater than 4 years. So then we talk about atypical femoral fractures or insufficiency stress fractures of the femoral shaft, noted about in a case reports about in 2007. They've been studied in relationship to bisphosphonate use, but have been noted with other osteoporotic agents, both with denosumab and romosozumab. Patients often present with pain, achy in the thigh or groin. Nobody understands the pathogenesis of this. Incidence increases with a longer duration of antidisruptive use. A study from a large healthcare organization in California, they look in people who've had over 1.8 million patients greater than 40 years of age. Incidence was 3 per 100,000 person years with 2 years of use, 20 per 100,000 person years with 5 years of use, and 50 per 100,000 with greater than 8 years of use. Whereas one analysis of benefit versus risk of this bisphosphonate treatment of 3 years showed that treating 1,000 osteoporotic women would prevent about 100 fractures, including lead-based fractures, by causing 0.1 atypical fibral fracture. Again, the ethnicity, it varies by the study reports that it's seen most commonly in Asian and in white and Hispanic women. But in symptomatis, we see a lot in African women who are very thin or malnourished. And they also have other comorbid diseases like hyperphosphatemia or hyperphosphatemia as well. So this is the X-ray that we see. It's usually in the mid shaft. And with atypical fracture, a small beak of bone forms on the lateral femur surface. And this is where the fracture begins. This contrasts to with the more typical stress fractures that occur in the medial portion of the bone and progresses laterally. Clinically, when patient with osteoporosis presents with complaint of thigh and hip pain that's unrelated to any injury, always ask about antidisruptive treatment. It's important to obtain X-rays not only of the hip joint but also the femoral shaft. It's important to obtain X-ray of the contralateral side, since stress atypical fractures occur bilaterally. And if you see this beak, it's always important to refer them to orthopedics, because sometimes prophylactically these can be pinned, or some recommend using PDH analogs to cure this fracture. But all this referred to a real endocrinologist or an orthopedic. So we talked about drug holiday. So discontinuation of denosumab is associated with BFD decrease about 6.6% in the lumbar spine, 5.3% in the total depth within the first 12 months of treatment discontinuation. Vertebral fractures were reported to occur as early as 7 months after the last injection and 1 month later than the next injection should have occurred. So this graph shows that the decline of BFD after this at 18 months, when they were receiving the next injection, you see the BMD almost declines to baseline. And when you see a serum CDX or bone resorption marker that was well below when they were on treatment, but it goes back to normal when they discontinue treatment at 30 months. So only specific to bisphosphonate holiday, not for denosumab. So a bisphosphonate holiday is defined as a temporary discontinuation of bisphosphonates for up to 5 years. This period may be longer depending on the BMD and clinical circumstances of individual patients. Once a bisphosphonate holiday is initiated, pre-assist fracture risk 2 to 4 years intervals, and consider reinitiating osteoporosis therapy as early as the 5 years suggested when there is a decline in BMD or if they develop fractures. This was a Horizon pivotal fracture trial. Postmenopausal women would receive Zol for 3 years. In the post-study, were randomized to receive it for another 3 years or placebo. In the years 3 to 6, the semaglutide BMD remained constant in patients who came on zoledronic acid for 6 years and dropped slightly in the placebo group but remained above pre-treatment levels. So new vertebral fractures were lower in the Zol who received for 6 years, whereas the patients who received 3 years, the odds ratio is 0.51, whereas other fractures were not different. So patients at modest risk of fracture, example T-score of greater than minus 2.5 and more recent fracture, temporary discompression can be considered after 3 years of IV bisphosphonates or 5 years prior if they have been on more of bisphosphonates. Patients continue to demonstrate high fracture risk with the T-score of minus 2.5 or a recent fracture. Continue treatment with bisphosphonates or alternative therapy for up to 10 years with oral bisphosphonates, up to 6 years with IV Zol. Patients on denosumab, the fracture risk be reassessed after 5 to 10 years after therapy would remain at high risk of fracture should continue denosumab or be treated with other osteoporosis therapies. If denosumab is being discontinued, patients should be switched to another antidepressant therapy to sustain the effect. So hormone replacement therapy is very rare to use as primary treatment. Usually patients are on it for postmenopausal symptoms. They also get osteoporosis benefit. And women has initiated re-education. In the study, estrogen and progesterone reduced hip fracture with relative risk reduction of over 33%. Very significant. There is vertebral fracture about 35%. Estrogen alone reduced about 39%. Of hip fractures, about vertebral fractures again for 30%. The cavities these were our secondary points. We didn't know their BMD at baseline while they were treated. Again, the risks are associated DVTs or breast cancer. So again, the roxapine, it's a selective estrogen receptor modulator. The name is Calista. Decreases spine fractures about 36%. There were no benefit at the hip despite increasing DND. Presentation for reducing other therapies. There's 3 times increased risk of thromboembolic disease, hot flashes, flu-like symptoms, and edema. So we talk about glucocorticoid-induced osteoporosis. Glucocorticoids cause significant bone loss and also fracture. The highest rates of fracture occurs within 3 to 6 months of steroid therapy, and slow decline continues with persistent use. A steroid treatment is stimulated BMD increase in fracture risk declines. Who should be screened for steroid use in osteoporosis? Adults initiating or continuing steroids greater than 2.5 milligrams per day for greater than 3 months. Again, their risk stratified based on their dose. Patients who receive less than 7.5 milligrams per day. Again, patients who receive greater than 7.5 milligrams per day. And then patients who receive greater than 30 milligrams per day for greater than 30 days. And greater than 5 times per year. So if they're considered low fracture risk, if their frac score is 10-year risk of major vascular fracture is less than 10%, and at the hip less than 1%. So BMD greater than minus 1. So the treatment optimize calcium and vitamin D intake and lifestyle modifications, smoking cessation, limiting alcohol, reducing, regular weight-bearing exercises, regular resistance exercises. And if they are a moderate risk of fracture, where their 10-year risk of major osteoporotic fracture is greater than 10% and less than 20%, and greater than 1% at the hip and less than 3%, BMD score will be minus 1 and minus 2.4. Treatment, denosumab can be considered bisphosphonates or PTH or PTH-RP analogs. Avoid patients with use of raloxifene due to harm of venous thromboembolism and bromosumab due to uncertain harm with MI and risk of stroke. So high-risk fractures, if they're been on, if the frac score for taking a risk of fracture, major osteoporotic fracture is greater than 20% and less than 30%, and then at the hip greater than 3% and less than 4.5%. BMD score less than or equal to 2.5 but greater than 3.5. Denosumab or PTH or PTH or T analogs over IV or oral bisphosphonates. Romosozumab or raloxifene in a patient intolerant to other agents, it can be considered. Use of this oral bisphosphonates over no treatment period. So when to stop therapy? Continue active treatment beyond 5 years when they're on steroids, but switch to another osteoporotic drug in another class if they're at high risk. Again, if they're moderate risk, continue active treatment beyond 5 years, switch to another osteoporotic therapy in another class. Off steroids, low risk, again continue calcium and vitamin D. Moderate or higher risk, complete osteoporotic treatment, but with a moderate risk, again, it is recommended to complete the treatment. In conclusion, treat high-risk individuals, particularly those with previous fracture. Consider bisphosphonates as a first-line therapeutic agent. Very high-risk patient, consider anabolic therapy, but maybe hard to get covered, can return to endos. Discuss side effects preemptively, reassess fracture risk after the patient has been on bisphosphonates for 3 to 5 years. Following the assessment, prescribe the bisphosphonates holiday for women who are on bisphosphonates and are low to moderate risk of fracture. All women with osteoporosis therapy should consume calcium and vitamin D in their diet or by supplements. Always replace vitamin D before we start any treatment for osteoporosis because unutilized osteoid is weak and it carries a high risk of fracture. Again, I mentioned about strontium, avoiding strontium because strontium is closer molecular weight to calcium. The calcium hydroxyapatite is the strontium hydroxyapatite. When you compare, calcium hydroxyapatite is more stronger, so use calcium. Do not recommend strontium inhibition. And this is the ACE algorithm.
Kind of terrible graphics. It's just terrible.
Yes.
Clear as can be. Yeah. I have a question.
Yes.
Do you ever, so the hypocalcemia risk with denosumab in particular is significant. Do you ever check 125 vitamin D or give an active vitamin D prior to therapy, whether you need to continue it or not? I mean, especially in the CKD population.
I discussed with the nephrologist before I prescribed 125E for patients for CKD stage 4.
I used to do it myself.
Yes. The reason is what they were concerned is because it causes hypercalciuria in some patients, and they think that could be causing decline in the AGF4. So before I initiate, I will check at 24-hour urine calcium in some of those patients, and then I prescribe calcium in those patients. And especially for a shorter period of time, maybe for 1 month or 6 to 8 weeks, and after that I discontinue.
It's surprising. We see these celiac patients. So I see celiac patients. They may have type 1 diabetes, may not. I may see pancreatic diabetes. They're also poor absorbers. I also see pernicious anemia patients with or without type 1. There are lots of reasons for poor absorption of minerals. So everyone worries about vitamin D, but you do a 24-hour urine calcium and it's quite low.
Yes.
And they're just chronic poor absorbers. So their PTHs are a little bit elevated, 24-hour urine calcium is a little bit low, and they're on calcium.
Yes.
So I think we have these complicated patients that are at risk for hypocalcemia.
But unfortunately, when you have fewer agents that you can use, so So nowadays I've resorted to a time where I use IV bisphosphonate. I give this the first dose of request. Then I check a CTX or an ATX the following year. And if I see an improvement in BND, I actually give them a holiday for 1 or 2 years. And then I use it again in 3 years, it shows a decline. So, that cat piece where I can use zolgonic acid for more than 5-6 years because I use it every 2 or 3 years. And that's what my professor just taught me. So I've been doing that and experienced well.